now deal with some real challenges here, because this therapy is about closure or occlusion of the appendage. And we all know that in up to at least 25% of cases, we leave some leaks there after putting in a device. That's one major challenge. And the therapy is also about preventing stroke. And we all know that we can actually, with our devices, induce a device-related thrombosis that increases the risk for the patient of stroke. So that is two real challenges that we have, and we have to discuss, first of all, how to diagnose and how to manage both DRT and leaks. And Kasper Korsholm is the first speaker. And Kasper has done a lot of LA research related to imaging and related both to leaks and DRT. And Kasper will tell us about definition of DRT and leaks using cardiac CT.
Thank you. So these are my disclosures, and I want to say, as I've written here, my main disclosure is that I would favor a CT myself. But I'm not trying to convince people to convert to CT today. I know that CT will never replace TE completely, as you will see also in my slides. But let's have a discussion about a CT diagnosis of DRT and PDL. So as Erik already said, DRT is associated with thromboembolism. It varies the incidence across major registries and clinical trials, and probably also a bit about the modality used for diagnosing and the timing for follow-up. In my opinion, diagnosing device-related thrombosis is difficult. This is the criteria as used in the PROTECT AF on echocardiography, and on the right-hand side you see a study looking at the adjudication process. 3 reviewers were blinded, and they disagreed in a third of all cases whether it was thrombus or not thrombus. So despite being a core lab, it's difficult to diagnose. And now we also have CT, which may complicate it even more to have more modalities to look at. And on CT, we have shown that we see perhaps a bit more. We see these hyperattenuated masses on the surface, and not all may represent thrombus. Some of it may represent device healing. But these are the 4 criteria or things that we look at on CT when we are trying to classify whether it's thrombus or healing. I've brought a few cases, and first, the device-specific design that we look at is illustrated here on the Watchman device, where you, on the right-hand side, see the ICE images during the procedure, and you see that the device membrane is loosely bound to the device, so it creates an area or a cove, the subfabric space beneath the fabric. And we cannot see that on CT, so when you look at the 2 CT images on the left upper corner, you see that there is hyperattenuation that could be considered to be on the surface, but in fact it's underneath the membrane, so it's intra-device. We've also seen that at animal studies, as you see in the right lower corner. I brought a few cases, and this is the first case where we did follow-up CT, and you see there is a hyperattenuated mass located in the screw hub cove, but it's protruding into the atrial cavity. It has an irregular surface, and there's no continuation onto the atrial wall, which we usually consider to be low-risk features. So we were actually in doubt whether this was thrombus or whether it was a subfabric. So we did a TOE. So TOE cannot be completely replaced. But as you see in these TOE images, you see that the membrane of the device is asymmetrically protruding into the lumen of the left atrium. And clearly the changes we saw on CT was subfabric. hyperattenuation. And that is nicely shown by Dr. Erik in this in vitro model, where you see that the subfabric or the fabric of the device can be asymmetrically located. Second case where we were in doubt also, you see there is a hyperattenuated mass on the surface of the device. It's rather thick, but it appears to have a smooth surface and continuation onto the atrial wall. And this particular patient, and I think that's also important to recognize when diagnosing DRT, is that patients we treat tend to be bleeders, and this patient had a very high risk of bleeding. So in this particular patient, we decided that this was likely healing, and we did not escalate the anticoagulation therapy. He underwent repeated CT scans 1 or 2 months later, and there was no change in this hyperattenuated mass. Finally, a bit more straightforward case. On the left-hand side, you see the images. There is a pedunculated, hyperattenuated mass protruding into the left atrium. I think everyone would say the risk of embolization is likely higher than the 2 other cases we saw, and this is what we consider thrombus. And after 3 months of warfarin, the change is completely resolved. So this is definitely device-related thrombosis. We have summarized that into these categories where we grade them from 1 to 3, and we have the device-specific subfabric hyperattenuated thickening on the Watchman device. And then we look at low-grade and high-grade features, where the high-grade features we have defined are a pedunculated appearance of the hyperattenuation, an irregular surface of the hyperattenuation, and there is no LA wall continuity. And grading of 2 or 3 is considered definite device-related thrombosis, whereas low-grade changes is more likely to be device healing, and we do not treat that. I think an important thing that we also have discussed with the ELAACC score as well, we need to have reproducible measures, and this is a study in collaboration with Mayo Clinic, where an experienced cardiac CT reader and a novice reader compared the intra-rater and the inter-rater reproducibility. And the novice reader had 5 training cases before completing the study. And as you see, grading between low and high grade had great reproducibility. Also, Dr. Erik has shown that this classification into low-grade and high-grade changes actually correlate with clinical outcome. And obviously, in my opinion, we need more studies to look into that and whether our changes, what we see on CT follow-up, is correlating to outcome, worse outcome. Moving on to peri-device leak. This is not uncommon to find peri-device leak, and that definitely varies across studies, as you see here. It also varies across the modalities used to diagnose peri-device leak, and it's probably also a bit operator dependent whether there is a leak on TOE or not. And here you see some of the studies using both CT and TOE follow-up. There is a discrepancy between the 2 modalities. And the difference is that CT does not detect flow. TOE detects flow, and CT detects whether there's contrast in the distal appendage, called contrast patency, LA patency. And then we diagnose whether there are anatomical gaps adjacent to the device. We have seen studies like this from the NCDR registry showing an association between leaks and adverse events, stroke, TIA, and systemic embolism. It's a modest association, and I think my personal opinion, and I might be attacked for this opinion afterwards, but classifying leaks as a 1.5 millimeter or 3 millimeter is too simple. And it cannot all have the same risk of stroke. And we know also from observational studies that patients with large atria have a higher risk, or it's a predictor of PDL. So is PDL actually the driver or the contributor or just a bystander when looking at this? I don't know the true answer, but as you see on the right-hand side, most of the leaks we see are also crescent-shaped when looking at them on CT. And when you look at TE, it depends on how you actually look, how large you measure that periodized leak. So in my opinion, a better way to classify leaks is according to the mechanism. Not only the size, that is also important, but the mechanism of the leak is important. Whether it goes into, it's a completely uncovered lobe, whether it's just proximal LA tissue that is uncovered, but there is actually not that large leak into the appendage, or whether it's a proximal device creating a small leak just beneath the device membrane, or it's only a disc leak for disc lobe devices. I think we need to look further into that in the future. When looking at the CT studies classifying PDL, all of them start by looking at whether there's contrast in the distal appendage. And thereafter, they vary a bit, but it's common between the studies that they look at whether there are gaps adjacent to the device, and then they try to look at the mechanism of the leak. This is how we decided to do it when we got together some of the CT users across European and North American countries and Sanchis. And what's important is that we measure the Hounsfield units in the distal appendage and in the left atrium, and it's a ratio between those that defines whether there is LA patency, and then we look at contrast gaps adjacent to the device, and we try to measure them at specific points. This is again tested, the reproducibility of these measures. It has a high reproducibility for grading the PDL and also for diagnosing LA patency. But when looking at classifying the mechanism, the observers disagreed, and when looking at the intra-rater reproducibility, the trained operator or reader had higher reproducibility measures. So this obviously, it takes a bit more training to try to classify that, and I think we need to work on that in the future, how to classify leak mechanisms. This is how we have proposed to manage CT-detected leak, and I think we'll discuss that further in the next session. Then finally, and I think this is a bit provocative, but I asked ChatGPT to provide images of a patient undergoing cardiac CT, and as I started out, I would prefer to undergo CT instead of TOE. And on the right-hand side, you see the TOE, and I'm not sure whether it's the patient or the operator himself who has performed the TOE, but he's clearly a bit frustrated, and perhaps he's found out that it's not that comfortable to undergo TOE. So that was it for me.
Thank you very much, Kasper. I think that we should continue immediately with the TE perspective. You have nicely demonstrated that we have some reasonable definitions of DRT and leaks using CT. And Christoph Hammerstengel was the one that actually should do this talk. He is down with influenza, and Nina has been so kind, together with Laura, to stand in and talk to us about the definitions of DRT and leaks using transesophageal echo.
Yeah, thank you very much, Jens Erik. So obviously, Christoph he sent his slides, but unfortunately, all the videos in the slides didn't work. So Laura and I had a tough time to create something. And so we hope we can give you some insights in what we see in TE. So the definitions of DRT and leaks on TE. So what is different? So let's start with DRT. And I think an important question is, what is a normal healing? And normal healing, obviously, is endothelialization. And what does endothelialization mean? So it's a growth and the migration of endothelial cells to form a smooth, protective inner lining on blood vessels, medical implants, like on our devices. So what does it suggest? It's just one layer covering our devices. So in contrast, what is a thrombus? A thrombus is a formation of a solid mass of blood components. It includes platelets, fibrin, red blood cells, and this may occur when we have some coagulation disorders. It can be activated, slow flow, for example, around the devices. So it's a different story, but how can we really differentiate between these two issues? And if we see that endothelialization is something which is normal and it's normal healing, does that mean that any formation on the device that exceeds the thickness of one layer, is this a thrombus formation? So it's getting more and more difficult. So now we heard, and the appearance of a thrombus can be completely different. So we can have a thrombus which is nicely attached to the device. We can have mobile ones like here, which looks frightening. And very frequently during procedures, you can see something like that. It's just a string-like structure. Yeah, it occurs, suddenly it disappears. So we have different appearances of thrombi during the procedures and after the procedures. So a thrombus, obviously, is not the same as another thrombus. So if I would look at these appearances of the thrombi, I would say, well, this looks more frightening, definitely, than one of those. So what is a frightening thrombus, and where do we have to fear that this patient has a higher risk of stroke? So now the CT are coming, and it's getting more complicated, because now we realize that we have hypoattenuated thickening. So, and Kasper already showed us, well, we have a grading now, which should make it a little bit easier. So we graded in different scenarios. So we might have it, so we have seen an example where it was subfabric, but we call it grade 1. If it's sessile, less than 3 millimeter. Less than 3 millimeter is definitely more than one layer of cells. And if it has a wall continuity and a smooth surface, yeah, everything that protrudes into the cavity, so this is something we should consider to be a thrombus. And so now the question is, we see hyperattenuated thickening with CT. Can we see that with TE? If you do a normal TE study, usually not. So what you have to do is to find it. You have to do a contrast study. And if you do that, you can indeed find hyperattenuated thickening. The question is, if it's grade 1 hyperattenuated thickening, do we really have to do that during follow-up? So there are a lot of unanswered questions, in my opinion. You've already seen this slide, and I think it summarizes everything very nicely, what we know at the moment, and it also gives us some insights what are the gaps. So we know it's not infrequent, 2 to 4% occurrence of DRT in 1 year. We also know that a not neglectable amount of DRTs is occurring 6 months after the implantation. And this means, so usually these patients are not in the frame period where we look after the patients. So this also has to be taken into consideration. And we also learned that the DRT is not a benign disease, so we have an increased risk of stroke. So the classification we are now relying on is more or less what we see down here. So everything that protrudes, so this is my interpretation, everything that protrudes into the cavity is something we have to consider as a thrombi. So this is maybe the future. How can we prevent it? So we might have better devices, yeah, surface coverages, which are better to prevent thrombi to form on the surface of the device, some medication. So this might be something, better device design. So this might be something which could be a future aspect to prevent some of these DRTs. So if you look at the predictive factors, we have a couple of clinical factors. I mean, this is something we can't rip off. So obviously, the only thing we can really influence is the implantation depth of the device. So this is something we have to keep in mind that this can help. And this is also something you have already seen. So if you have the grading and if you have a thrombus or whatever it is, a thrombus layer, because there's a gray zone in my eyes in between a real thrombus and this endothelialization, which should be just one layer. But what we can learn from this study, obviously, so if you have a high grade heart. So this is associated with a higher rate of stroke. And this is maybe what we can call a real thrombus. But in my eyes, there's no real definition what a thrombus is. So here's a case example. And this demonstrates maybe that it's not always that easy. It's an 80-year-old man, so typical patient, permanent atrial fibrillation, recurrent bleedings, gastrointestinal. So this is implantation. It was very uneventful. You see, we don't have a high rim. The implantation of a 25 millimeter Amplatzer occluder. The patient was sent home with aspirin and clopidogrel, dual platelet and coagulation. So this is the first follow-up. Don't ask me why it's 2 months after the implantation, so usually do it a little bit later, but this was the first follow-up. And you can see something here, which is it hard in your eyes? Is it a thrombus already? I mean, it's protruding. The surface is not super smooth. So I thought when I saw the patient, this is a thrombus because the surface is not super smooth. So we started a heparin therapy, and this is the next follow-up 2 months later, and you can see, well, it looks reasonable. No, it's the same patient, sorry, just playing with different types of visualization, yeah? So we have this irregular masses, so I think if we use this additional information, we come to the decision, well, this is protruding, and this might be a thrombus. Okay, patient got heparin, and this is the next follow-up 1 month later. And if you just look at the device, so I thought, well, this looks pretty nice. So we don't have anything which is protruding and is sitting on the device in several perspectives and several views. So we decided to stop heparin and go again further on with aspirin and clopidogrel, which was continued. So what happened? And we know that a complete resolution of DRT can be achieved in about 80% of the patients after a median day, and this is not a small, 105 days, in a median period, follow-up period of 105 days. So this is a pretty long period. Yeah, so it can resolve. So see what happens 3 months later, okay? So under aspirin and clopidogrel, so we had, again, a huge thrombotic mass. I mean, this time it's very obvious. This is a thrombus. Nobody would doubt. So what happened? The patient was, again, under anticoagulation. Yeah, and again, as you can see here, so this is still the big thrombus. And what happened under, again, heparin therapy? So it resolved, but not completely. Yeah, so if you look at this area, you still have some formation, thrombus formation here in this area. So heparin was continued. And so we have, no, let's go back to this. And 2.5 months later, so the thrombus resolved again. And Kasper, you already mentioned it. So is, for example, a peri-device leak, because if you look at this area where the thrombus formation originated from, so this was a small peri-device leak. Yeah. So is it a bystander? Is it contributing to the amount of thrombus? So a lot of open questions. The recurrence of DRT is not infrequent. Yeah, so we see that in over 30% of the patients. So what does it mean? So do we have to follow up these patients closer? Again, a lot of open questions. But we just have to keep in mind it's not uncommon. And we also have to keep in mind a lot of thrombi are not occurring in the first 6 months after the implantation. So the key messages from my side and Christoph's side, actually, the TE can detect thrombi. We can actually detect hyperattenuant thickening, but you have to look for it and you have to use contrast agents. CT might be the gold standard for the detection of any device adherent findings, whatever it is, and whatever the clinical implication of that is. But we also have to think what is prognostically relevant, and TE, so this is something we could see in the data, sufficiently identifies patients with a mass on the device which has prognostic impact. There are still a couple of open questions. So we still don't have a clear definition in my eyes, what is a DRT? And we have to come to a consensus in between CT and TE because we are looking at the same structure. The next thing is we have to see what is a clinical versus a significant value of CT and TE if you look at the prognosis of the patient, of the impact on the prognosis. So we also have to see if it can be a good value to look at these patients with heart with contrast TE, for example. And we have to define, so what is a follow-up strategy for these patients? So what should we do? How frequently should we do follow-ups in patients who have an unclear device adherent finding? Or, for example, in patients who had a stroke after left atrial appendage occlusion? So to summarize, no clear definition in my eyes and a lot of open questions to discuss. So as Christoph is still in bed and coughing, Laura will overtake the part on peri-device leaks.
So it's the same presentation, it's just the follow-up of the same presentation. So now we move to leaks, and I think that for me leaks even it's more difficult than device-related thrombosis. And in fact, I have more questions than answers, and I think that the discussion will be very nice. It will not be a very long part of the presentation, because at the end, in the initial studies, the leak was defined with 3 millimeters or 5 millimeters based on the color imaging through the device. And these cutoff values at the end, I think they were quite arbitrary, because I didn't find never like a quite study that sent me that 3 or 5 it's the correct based on something, was something arbitrary. And the other thing is that now that we are talking a lot about CT, 3D and so, how is the best way to measure these leaks? Because I think that we need to put something in common for the future studies. So the thing also is that what we know about the influence of the leaks on the follow-up of our patient, it's also not so clear, because in most of the studies, even leaks that are smaller than the larger leaks have more impact in follow-up. And this whole study was more or less if you don't have any leak, that if you have moderate, and if you have severe was better than not have anyone. In this one, more or less was everything the same. And other ones look at the follow-up, and they said that, yes, there are more thromboembolic events in patients with leak, but the difference among groups was not so high, and especially not for big strokes, small strokes. And I think this last study is the maybe most interesting one, because here it's a study where it's put a lot of studies, it's like a kind of review of previous studies and meta-analysis. And it's interesting because in some studies they evaluate the leak with TOE, in another studies they evaluate with CT. And at the end, the conclusions was that the device leaks that were found by the TOE were more related with the adverse outcomes that when we described that there was a leak with the CT, because it was not so clear what is happening with this patient. And I think it's a big problem, because some centers, they are making the following with TOE and another ones with CT. I think that today or along this year or whatever, we need to agree on some common definitions. So, and I think that we need better studies to really define what is the impact of these leaks. And we really don't know even what is the mechanism of these complications, because it could be thrombus that it's inside the appendage and goes out, or maybe because we have the leak, as the patient that showed Nina, is that the endothelialization is lower because we don't have contact all around the device. And another big question is that patency and leak is not the same thing. And with CT, mainly, all the studies were focused on patency, and it's not the same to have patency than to have leak. And for example, this very famous study, the Swiss Apero, the thing that we saw just in the middle, that is the difference among one device or the other one, when we evaluate with CT, there were no differences, but when we look for the TOE, the difference were almost the double. So we need to agree what are we looking and how are we looking for the future studies, I think. And regarding the kind of para-device leak that we can have, I think the ones that can matter are the ones in the upper part. If we have an uncovered lobe or we have a leak that is going all through the device, it's a leak. But maybe if we have an uncovered part of the proximal area of the appendage, it's more something related with device-related thrombosis. And we don't know what does it mean just patency without any leak. So another important thing, also another question, you see it's everything regarding question, is that with different devices, maybe we need different definitions of leak. Because we have, for example, amulet that it's closing with the lobe and with the disc, so if only we have a leak of the disc, is the same that if we have a leak in the disc on the lobe. It seems that you can have a steel appendage with the lobe, with a small leak in the area of the disc. If we have a lambre, for example, there is a big cavity between the anchor and the disc, so maybe here it's something that matters, the leak of the disc. And with the Watchman, we only have one lobe, so probably if we have a leak, we just have an open appendage. So this is an example of a real leak of Amplacher that is more a dislodgement of the device, and we saw that it goes all through the device. Here, in this case, it's an alambre, and you see this big cavity. We don't know what is happening with this. We don't have studies on that. This is same patient, just looking at this neocavity. And if we are making with 3D the measurements in the CT, when we are talking about the dimension of the leak, not the patency, why don't do the same with the echo? And I think it's not so difficult. We saw previously images of MPR. Maybe if we are trying to make the same definitions, it could be worthy to make these measurements in MPR as in the CT. And this is quite interesting because with the MPR, we can also see, for example, in this other study, how this Watchman is a little bit dislodged. So we have more information regarding that. I think only color is not enough, and it's not the same that we are looking in the echo. So I just want to finish with these points for discussion that we need a definition of leak in each kind of device. We need to make a common definition, I will set for echo and for CT, on how to make the measurements of the leaks. I think that maybe we need to work into have a proper definition of the cutoff value based on prospective studies. And we need a better understanding of the patency, because it's true that there is no thrombus that is going out of the appendage, but maybe it's a problem of endothelization because we don't have covered the device. So we need more info regarding that. And this is all for my side.
We have a lot of questions to discuss, but I think that we have a related talk because we already alluded to what is the timing for following up after left-aided appendage closure. So I will call upon you, Roberto, but I will also ask in the audience here, is there anyone here that will not do any follow-up after left-aided appendage closure? No imaging follow-up. Do we all agree that this is required? Yeah. Okay, so how many will do imaging follow-up using CT? That's pretty many here. And how many will do imaging follow-up using TE? So maybe half-half. So that just becomes more interesting. But Roberto, before we take the discussion of both leaks and DRT, let's hear your perspective on when to do follow-up imaging.
Thank you very much, Jens Erik, and thanks to the ELAACC committee for the kind invitation. So, let's start with the current recommendations about the timing of imaging follow-up. So the latest expert consensus document from Europe and the US recommend to perform an imaging follow-up at 1.5 and 6 or 6 months after the procedure, and suggest to repeat this imaging follow-up 12 months after procedure. But let's take a look at the evidence based on which these recommendations are based. And so, ideally, the best studies would be randomized clinical trial that compared 2 different timing follow-up, but we know that these studies are not available. the high quality studies based on which these recommendations are based are the randomized clinical trial that prove the non-inferiority of LA closure as compared to oral anticoagulation. And we should intuitively consider the imaging follow-up used in these trials in the ELAACC group like standard of care for our clinical practice. And so let's take a look at these trials. The pivotal trials, PROTECT-IF and the PREVAIL trials that show the non-inferiority of LA closure as compared to vitamin K antagonist in terms of thromboembolic events. These trials had 3 TE, one at 45 days, one at 6 months, and another one at 1 year. Then the option trial, finally a contemporary trial published last year, proved the non-inferiority of LA closure as compared to DOAC in terms of death, stroke, and systemic embolism at 3 years. Well, this trial showed at 3 months, this trial had in the study protocol included a T or CT at 3 months and a T or CT repeated at 1 year. So, based on these 2 trials, we should perform a TCT imaging follow-up between 1.5 months and 3 months. And because this was included in the study protocols of these trials, and because was used this imaging follow-up to guide antithrombotic therapy. And then, according to the study protocols of these 2 trials, we should repeat an imaging follow-up at 1 year. But regarding this point, there is a lot of discussion and internal discussion in our scientific community about the need to perform this imaging follow-up at 1 year. And the reasons are several. One of them is the limited clinical generalizability of the results and the methods of the pivotal trials. Yesterday, Erik underlined how it's difficult to base our clinical practice on trials that were performed more than 10 years ago, almost 20 years ago, and with the different devices, with a different role of imaging, different patients. We had the learning curve in these 15 years, and the results of the PROTECT-IF had 88 implant success, so 88% of implant success. So generalize the methods results of this trial is not, might be not appropriate for the current clinical routine. For the option trial, that is a contemporary trial, we observed at 1 year, a PDL more than 3 millimeter in 2.3% of cases, and a DRT rate of 1.9% of cases. And the OACC management recommended by the study protocol was, regarding to the PDL, at operator's discretion, and in case of DRT, recommended by OACC. And so the clinical impact can be questionable about this trial. Then we have the studies that proved that show the natural history the natural history of the device-related complication, and these studies should be, we should consider the prospective studies that with a standardized and an imaging follow-up, and with a central core laboratory evaluation. So, a device-related thrombus. Regarding the device-related thrombus, we in the Watchman 2.5 population. Sorry, can I drink a bit? Thank you. Okay, thank you. So, according to the study with the Watchman 2.5, we observe a small increase of DRT at the longer-term follow-up, most likely due to the ELAACC interruption. Then, the natural history of DRT with the studies more recent, like the Amulet ID, we observed that we had a small increase of DRT between 45 days and 1 year, from 1.6% at 45 days at 1 year, 2.5 at 1 year follow-up. Then the Swiss Apero trial, where we observed at 45-day CT scan a 1.9% of DRT that reduced at to 1.2% at 1 year, and this was a trend that was different as compared to the trend that we observed in the previous trial. If we observe in the Amulet AD, we had a small increase of DRT based especially in the Watchman group, and most likely due to the use of oral anticoagulation in the first 45 days. Whereas in the Swiss Apero, actually the antithrombotic therapy after procedure consisted of antiplatelet therapy only in more than 90% of cases. These are the largest retrospective studies on DRT, including 156 cases and 337 cases in the American registry. They show the bimodal distribution of DRT with between 18 and 36% of cases detected later than 6 months after procedure, and with the incidence that was inherently linked to the imaging follow-up and the post LA closure antithrombotic regimen. Let's take a look at some other device-related complication, the peri-device leak. The peri-device leak that in the Watchman 2.5 population, in the Watchman 2.5 studies, decreased over time in terms of rate and size. In the Amulet AD study, we observed a similar trend, but with some PDL that may occurred later at the later follow-up as compared to the early follow-up, and then the Swiss Apero, where we observed again a small reduction of PDL side gap leak between 45 days and 13 months, and but this reduction was less frequently than the reduction observed in the other patent appendage subtypes. These are data not yet published. Then let's take a look at the pericardial effusion. Last year we shared our experience from Bern, including 1,023 cases, and we observed that the pericardial effusion were especially observed in the first 7 days after procedure, especially in the first 6 hours after intervention, and that the cardiac tamponade detected later than 45 days was extremely rare. Then finally the device embolization. This is the largest multicenter retrospective study, including 125 patients. 1/5 of the cases was observed after later than 45 days. And then another kind of evidence are those studies that exploring the clinical impact of a specific timing follow-up. There is this very nice study published in 2022 regarding the American population, including the 2 pivotal trials and 1 prospective registry. In this study were included all patients receiving Watchman 2.5 with a PDL accessible at 45 days. Well, the authors compare the 5-year ischemic outcomes in patients with versus those without a PDL not significant, and the authors observed that the thromboembolic events were higher in those patients with a non-significant PDL as compared to those without, but only at 1 year follow-up. So the PDL detected at 1 year seem more prognostically relevant than those detected at 45 days. So based on this evidence, we might recommend to make a TT always pre-discharge, but still we have confusion and open question about the need to perform a systematic one-year imaging follow-up after LA closure. I summarized here the evidence why we need to perform or why not the systematic one-year imaging follow-up. Why yes? Because was recommended in the study protocols of the main randomized clinical trial supporting LA closure, because 1/3 of DRT seems to occur later than 6 months after procedure, and because 1-year PDL were shown to be the most clinically relevant ones. Why not? Because the clinical impact in the option trial of the 1-year follow-up is still questionable. The DRT was very low, and several PDL were managed conservatively. The benefit related to the DRT and PDL management is still uncertain, but we will see in the next session, and the patient comfort and the cost. So this is a personal opinion. We probably need to better select the patient who should be reassessed at 1 year, considering the risk factors for DRT or PDL persistence. And in this regard, with the team of SwissAppro, we are trying to, we made a sub-study that is still under review. We assessed the morphological characteristics of the leak at 45 days, of the peri-device leak at 45 days, and we observed that when 2 of these 3 criteria are satisfied, there is a higher risk of peri-device leak persistence. So area greater than 37 millimeter, radial diameter more than 3 millimeter, and an angle device LA greater than 39 degrees. So, in conclusion, LAACC imaging follow-up should be considered an integral part of the LA procedure as the combination of pre, peri, and post-LAACC imaging, along with LAACC itself, has been shown to be non-inferior to ELAACC. Available evidence support the need to perform an imaging exam between 45 days and 180 days after procedure, and further studies are needed to better understand the real clinical impact of systematically performing a 1-year imaging follow-up. And thank you very much for your kind attention.
Thank you very much, Roberto. Stay up here, and Kasper and Laura, please come up here so we can have the discussion here. So, you have an interval for your recommended follow-up imaging, 45 to 180 days, but now you are only allowed to give one specific recommendation. What is you doing in your own center? What do you believe is the correct early time follow-up?
So in our center, we perform systematically one imaging follow-up at 45 days with CTT and another one at 1 year. Probably based on the evidence available so far, of course, this imaging follow-up has 2 kind of purpose, a clinical purpose and a research purpose. Probably based on the available evidence, we might consider postpone to 3 months, maybe, based on the evidence related to the option trial. But I think it will not change so much our clinical practice, since we are not, in our center, we don't give oral anticoagulation after procedure. So I don't think we will observe any change, relevant change in terms of device-related complication between 45 days and 3 months due to our standard antithrombotic therapy.
Yeah, I think it's reasonable. I mean, we don't have concrete data to support it, but it's reasonable to do it in between 1 month and 3 months. I think the more important question is this 1 year story. So if you really look at the data, and you might miss 30% of device-related thrombi. So at the moment, it's a gray zone. We can't really predict which of the patients would develop, because we don't have predictors. So which patient would develop a thrombus in between 6 months and 12 months. So what is your rational approach at the moment? So in which patients do you do the 1 year follow-up?
So we actually do that in all our patients just for research purpose. If I should give some suggestion to the clinicians when to perform at 1 year, yes, I would focus on the device-related thrombus predictors, but that are all, so far the predictors are based on TE studies, so, and so I mean reduced ejection fraction, history of device-related thrombus, chronic atrial fibrillation, so big atrium. In this case, probably I would suggest to repeat at 1 year an imaging follow-up. And with the Swiss Apero team, we are trying to identify those leaks that, with the characteristics that predict the persistence of the leak at 1 year. We identify these 3 parameters. That means a big leak, bigger than 3 millimeter, and the leak, peri-device leak related to the off-axis angle that really hardly go to disappear at 1 year. This persists, in our experience at least.
You will get your question in a moment, but I want to see how many in the audience here are doing routinely a late follow-up imaging after 1 year, about 1 year. So that's 1, 2, 3, 4. Yeah, and how many are only doing the first within the interval, within the first 3 months? Yeah, so that's the majority. Sven?
It's just a comment. I think we have to understand why these controls were done in the former times. The trials started with implantation of a new device, and we have given warfarin plus aspirin in the beginning, and then we want to see what happens before we stop the medication. And I think this is important to know, and this is can also lead us today. So if you now doing NOAC for 3 months for the Watchman, you should look on the device if there are leaks larger that you want to have, and then you can decide to go on with the NOAC or to stop it. And for AMULET, you would be depends a little bit on the length of the depth, I would say, and then you can also decide to stop. And I think this was the reason for these controls, and therefore also the 6 months controls in the trials when you then switch to dual antiplatelet and then later to aspirin.
So, Sven, I don't have the exact number in mind. If there have been thrombi during the anticoagulation period of Protector F, do you remember that? Because I think the development of thrombi under anticoagulation was very low. But very then low. You have this jump, it's going up if you discontinue anticoagulation.
I would think that the first TOE after 45 days were to look if there are gaps larger than 5 millimeters. Because in the protocol stands when you have a gap more than 5 millimeters, then you cannot stop the anticoagulation. This was the first view on gaps, not so really on device-related thrombus.
Well, I would argue a bit along the same line. I think the optimal timing, if you're screening for DRT, the optimal timing strongly depends on the prophylactic scheme you're using. And for example, I don't think it makes a lot of sense to look at the option data because option are not bleeding patients. They get 3 months of full dose anticoagulation. Nobody's doing that in the bleeding patients. So I think it makes more sense to define the optimal timing in function of when you switch to single antiplatelet. Let's say 1 month after cessation of whatever prophylaxis you're using, or 2 months, we can decide, we can reach consensus, is the optimal timing, rather than saying 45 days, which will, we don't have a consensus on the ideal, you said it yesterday, Erik, we don't have a consensus on the ideal duration of dual antiplatelet if you're using dual antiplatelet, but we can say that when you switch to aspirin, 1 month later is the ideal timing, for example.
That's a very good point. Martin, you had a comment?
Maybe going into that direction and picking up another aspect, you mentioned the recurrence rate of DRTs, and I've seen that also a couple of times. I'm really afraid of that these days. So once the thrombus is resolved, I keep these patients on low-dose NOAC, irrespective of whether bleeding was the reason to show them, because I think it's rather the rule than the exempt.
Yeah, I don't actually have a good explanation for that. I'm interested in your thoughts because, to my feeling is, I mean, the follow-up period after a thrombus tends to be very close. Yeah, you see a thrombus, and 2 to 4 weeks after, you want to see what's going to happen. Is it going to increase? Is it going to be better? So you do another follow-up, so 4 weeks after. And to my personal feeling, I would think many of these patients, you don't really see residual thrombotic material, but maybe we didn't look close enough. And if there's residual thrombus, the risk is much higher that the thrombus will re-increase after. So we need maybe better imaging to really tell, or we should use contrast to really tell if the thrombus has resolved, or we used CT in these cases.
Sorry. We will come back to this discussion. I want to add one thing to the discussion about timing on follow-up, because we alluded to device healing and endothelial overgrowth, and it's not happening like we just have ingrowth of a single monolayer of cells over the device and that's it. That's not the natural history for device healing, because we have done early scans and it starts actually with a flat layer of thrombus that can be a kind of scaffold for tissue ingrowth, and then with time this will regress and there will be an endothelial layer left back. So if you come very early, there's a big chance that you still see part of this initial healing process. So I believe that you should not go for 14 days, and I believe that probably depending on the medication, but we definitely have to come over the very early healing phase.
Just can I do one more comment? Yeah, I think that we have to think about even the kind of patient that we have, because sometimes we have a very fragile patient. They cannot do any anticoagulation. So I think that we have to think which is the correct timing, even on the base of the patient, because if it's a very old patient, I don't know if we need to do 1 year control if a patient that cannot do any anticoagulation. If we move to younger patient where we do like option patient or other patient like this, probably we can do more control because we want to be more, the patient is totally different. So I think that we have to start from the patient for deciding the correct timing.
Yeah.
Good
so
point.
One thing is that, just to me, and going just to Tom's point, I think that we need an imaging test after we put the patient on the indefinite treatment. So I mean, if the patient is going to be on nothing, so you need imaging test maybe 1 month or 45 days after. If it's going to be in single antiplatelet, same thing. If it's going to be on ELAACC, because it's an ELAACC, it's a patient with high risk, and you're going to leave the patient on oral anticoagulation, so it's enough. You don't have to repeat it. So it's a high risk, but you already test, like the situation with the long term. So I think that that's the thing. And I'm really scared because, what you show, Nina, so like the first case that you showed that the patient was on that, then you give heparin. And then it looked like this thin layer, like a healing and all this. So I'm pretty sure if this patient gets like low dose apixaban, the first echo will show that. And then you downsize, and if you don't repeat, then you can have the thrombus. So I think that we have like a lot of thrombus after 6 months because there is a downgrade. So anytime that we have downgrade of treatment, I think that we should repeat, maybe 45 days after or something like that. Yeah.
And I think that it's also important maybe to do the second imaging test in patients that we think that they have high risk for complications. For example, if you have a leak, I think that you need to do a second test just to know how it's going. And I think that also if we have an extreme angulation of the pulmonary ridge, that we know that it's related with thrombus, maybe it's worth it to do the second test, especially in patients with chronic AF and large appendages.
So there's a lot of good arguments here and a lot of good factors to take into consideration in this timing, and this can be a task for this group here to actually come out with some recommendations and some guidance. One more thing. Adel, are you on the podium now?
I have to give because I have a lot of slides and a consensus. I have to give a consensus.
Okay, but
you will not get a consensus, no?
No, I was going to just spend a few minutes about what Kasper told us about definition of DRT.
Okay.
Because this definition was derived from CT follow-up.
Okay.
But in my mind, it's completely compatible what you can also diagnose with transesophageal echo. You might miss what we call low gray hat, but it's not important. So my point is that I think that we have a very useful classification that can be applied both to CT and to transesophageal echo. And do you agree on that? Because that's not the message out there. It might be useful for other cardiologists or implanters to accept that this is actually something that are uniform both for CT and TE.
I mean, nobody wants senseless follow-ups. Okay, I mean, I think we all agree on that. So I think we shouldn't look for something, if you have the understanding that a low-grade thickening, whatever it is, on the device has no prognostic implications for the patient. I think it's very reasonable not to go for additional follow-ups. Yeah, and as I already showed in my presentations, I mean, even you don't have to look with contrast if you don't see something on the device.
I think one also very good task for this group could be to look upon treatment of DRT. I know this is not on the agenda today, but it's a little bit confusing, and different centers use very different strategies. But I think to collect all the data that are out there and try to come with some consensus upon what do we do when we diagnose those types of DRT that we have discussed today. That would be very useful. And one factor that is also complicating things is that now we are not only treating bleeders, we are also treating patients like option trial patients. So I think that also really requires that we adapt our recommendations to a broader patient population.
And another idea would be, I mean, we're looking at very different kinds of leaks. So would it make sense, so for example, Roberto, for you it could be easy to look into data. I mean, if an open uncovered lobe has a different impact on the prognosis as a leak which is next to the device. Yeah, so it might be also very useful information, because if you find that an uncovered lobe has a higher risk, so this should be closed.
Okay, Adel, you need time. I see that.
I have time or not? I don't want to be on the podium on a purpose, but I was asked to give a...
But I mean, we also have the most difficult thing now, and that is really the leaks.
Yeah, sure.
How can we define leaks and be in agreement, CT and TE? Tell us your opinion and...
No, I will open the discussion again. Sorry, but let's start with what you have said just right now. So we have to stick on, I would say, at least for TE, it's all definitions. So that we are still using in almost all the trials. So the DRT is defined. It's basically what Nina said actually. So echo density on the left atrial aspect of the device, which is not explained by an artifact, which is inconsistent. I mean, it's exactly what you said with normal healing of the device, visible in multiple planes. So this is still the definition used from PROTECT-IF years ago. And then for CT, I think we have enough data now to testify that if it's a grade 2 or grade 3 HAT, I mean, that's probably a high grade one, and this is a definite DRT, which at least requires a treatment. So it's not so complicated actually. It's the size, it's the fact that you have a continuity with the LA wall, the fact that you have an irregular surface. If pedunculated, it's definitely a thrombus. So I know Kasper has shown some borderline cases, but most of the time you know that it's a thrombus on the device, and sometimes you hesitate. So that's all the definitions on TE and on CT. So I think everybody agrees about those definitions. And as Erik has said, I mean, he has provided almost all the data about that, that there is a good correlation when you take the same patient, you do the CT and the TE, it's almost the same. There is maybe one case that is borderline, but actually you can rely on both imaging modality to detect. So for surveillance of DRT, I think both modalities are good. No problem. So I think we agree. Now the problem is the leak. The problem is the leak. So again, a very old definition still used in all the trials. What is the definition of a TE leaks? So detection of a residual blood flow around the occlusion device. And I've heard Laura talking about gap on 3D, so this is already something different. You use color Doppler, so it's based on color Doppler with Nielsen-Kudsk scale between 20 and 50, and Nina has told me, explained me how it's important to adjust it according to the flow. So it's not so simple, but it's still the definition used in the trials. So the width of the jet is measured in multiple views, and the largest measurement defines severity. So I challenge people doing TE, not like Nina or like Laura, to probably they miss a lot of TE leaks and they say, oh, the procedure is good. And imagine if you do only an assessment during the case with ice or something like that, and you say, okay, I have no leak, but actually you have a leak. Or is it important or not? That we don't know. There is a big inter-observer variability, and the cutoff, for me, still remains unclear. Is it 3, is it 5? Okay, and on CT, you have one clear definition. It's the presence of contrast distal to the device. Presence of contrast distal to the device means residual LA patency. So we have a clear definition. It's a LA density of more or equal to 100 Hounsfield unit, or a ratio of the LA density to the left atrial more than 25% of that of the LA. So that's clear. That's no. I think this is all the studies, so that's relatively clear. But the problem, it's highly sensitive. It can detect even small leaks missed by other imaging modalities, so basically TE. You have to discriminate between intra-device leak or really peri-device leak. So, and some people now say that you cannot use the term intra-device leak. It must be lack of endothelialization. Okay. The cutoff for severity is really not well defined because you don't have any studies showing the prognostic impact of a CT-detected leak. And so that's a problem. And the most relevant issue is that it's very, very frequent. And even if you put that in the best hand, it's between 30 to 50% of residual patency on CT. So this, which is disturbing, which has nothing to do with TE. And still, in all the trials now, the Champion, Catalyst, if you have to use TE, it's the significant peri-device leak. It's still this 5 mm cutoff. And if you look at the definition from Roberto from Swiss Apero, it's even a little bit more complicated, but it's basically the same actually. You have a CT, it's the same definition of Hounsfield unit, blah blah blah. But the thing is that you can differentiate peri-device leak, intra-device leak, mixed leak, that you have both actually. It goes through the device and next to the device. And this one with no visible leak, which I think probably it's not prognostically important, but still, I mean, you have some contrast distal to a device that you don't understand what is the origin. And you take the same patient and you have sometimes 2 times, 3 times more leaks within the same patient if you use CT as compared to TE. So that's a big problem. So can you use actually CT for patency? Look, just show one example here. For follow-up. This is a case when my echo lab said that's a very nice closure, you don't have leak, it's perfect. Okay, and this is the CT of the same patient. So you have proximal lobe not covered, you have a peri-device leak, clear on CT, okay? And myself, I'm not a sonographer, looking back at the case, I can see that the proximal lobe here is not covered. So my TE operator say it's perfect, so if I have to put that in a registry, perfect, I have no leak, and you do the CT, you have a leak. And the only correlation that we have with leaks and prognosis is based on this meta-analysis and some studies from the US. When you have a leak, especially the largest one, I mean, it starts with any leak, but really the cutoff is that 3 and 5 mm really increase the ischemic events. I mean, the numbers are low, but at least there is, the prognosis is relied on TE data and not CT data. And if you look at CT, then it's just the opposite. It's so sensitive that you don't have a prognostic impact on CT. So if you detect leak on CT, what do you do with that? What do you do? So it's very good to, so how do you assess it? So it's very complicated. You have to scroll the device from proximal to distal and look at everything. So who is going to do that on a regular basis? Personally, I just look at the mechanism and if there is patency or not. But it's very useful to detect the mechanism. And it's very frustrating for an operator like me, for example, when I see that I have 40% of LA patency on CT. And when the radiologists say to the general practitioner that, oh, be careful, this patient has an open appendage, it's not open, there is some contrast still filling the appendage, but, and still I do TE and CT because for a research protocol, I have two different protocols. My TE guy says it's perfect and the CT say there is patency. So, and then I have to explain to the patient that it's not, it doesn't have any impact. And so if you look at this consensus document, you see at the bottom that although it is very clear for DRT, it's very clear, I think we stand up with a very good recommendation. For PDL, we don't know. What is a significant PDL? We don't know. And if we don't know, we are going to overtreat the patient for nothing. Of course, if you have a super large proximal lobe, but if you have just small gaps filling the appendage distally, what are you going to do? In the US, they're obsessed about that, so they are putting plugs and coils and whatever, because they don't like to have an open appendage. But this is a study I found like 3 days ago. It's a study from China that no one is talking about. No one is talking about this study. It's a CT follow-up after Watchman 2.5 following ablation. It's part of a Chinese registry when they do ablation and concomitant closure with Watchman 2.5. And they have a large series of patients, like more than 500 patients. They have a 3-month CT follow-up. Again, you see the same number. They have more or less half of the patient have a complete closure on CT, so good closure, and almost half of the patient have patency, which is something that is you see that on a regular basis when you do CT follow-up. And on those patients with LA patency, 37% have a visible PDL, and the 10% have no visible PDL. And the median follow-up is, as you can see, relatively long. And what they show is the first time that I see that a residual CT patency has a prognosis impact. Relatively large, actually. Ischemic stroke and TIA, there's a significant difference. And all-cause death, there is a trend. And if you look, they've even differentiated patency with visible or without visible PDL. And both of them are associated with a higher rate of ischemic stroke. And even a residual PDL on CT has also a prognosis impact on all-cause death, which is totally new for me. And they've used the same cutoff, and I disagree with that, they've used the same cutoff as TE. So, for example, no PDL or mild is less than 3. Moderate for them, they just do the same correlation as with TE, so they say 3 to 5 is moderate, and severe is 5. But can we really correlate a 5 mm TE leak with CT? Sometimes a 5 mm leak on TE can be a super huge leak on CT. So for me, you cannot do a correlation. And that Roberto has nicely depicted, so I will not go back to it. So my major point here is what do we do with CT leaks? What is the cutoff? What do we have to do with it, and so on?
Kasper.
Just to comment on this, I would like to question how should contrast patency explain a difference in all-cause mortality? These patients are likely sicker than those not having contrast patency in my head. That's how I read those data. So they probably have larger atria, higher CHA2DS VAS score, more vascular risk profile, and thereby the stroke rate and all-cause death is higher. That would be how I interpret those results. But because I cannot see how a leak size of 1 millimeter should explain all-cause death. Disabling stroke is likely non-significant.
Mm-hmm. Yeah, but it's the same concept for TE leaks. It's the same concept. So, yeah. But regarding my first question, so what do we do? Actually, I have to write a chapter on the follow-up of patients with imaging. So first of all, I will have to use the old definition of TE leaks, but when I talk with Nina and Laura, they have totally other way to detect leaks. So do we have to refine our way to detect leaks? Because if we use the way our Laura and Nina are detecting leaks, we will detect more TE leaks than what we do actually.
Yeah, but isn't it the way how we measure? I mean, we could do it similarly. I mean, if you do a CT, you use MPR and you trace the area. You look for the width, that's what you did, and you found, okay, the width has some implications. But we never looked in all the studies, Protector F started with it, we never looked at the extension of the leak. So we have to find a consensus how to measure it. And I think in my eyes, and Laura, I think you will agree, I mean, the only way to do it is using MPR and have the same approach to the leak.
I agree. I think if we just have a more rigorous TE protocol, we'll find the same as we do on CT. And I think, Laura, we both saw that there was actually a leak jet on the TOE you showed.
It was a big one.
Yeah, so it was just missed by 2D. And that's why TE is very operator dependent, where CT is a bit less operator dependent. And I think that may explain some of the discrepancy.
But how would you define the success? Now, when you do a trial, you define the success rate like a good closure with a TE leak of, even if you take 3 mm, that will define the success of the procedure. So what do you do then with CT? Do you include CT in the success of a procedure, or no? You will have a low success rate then if you include CT.
But maybe you need to change and define it with MPR, measuring the same that then he will measure in the CT.
But then you will detect more leaks, and what do you do with that then?
No, but the thing is that with CT we find a lot of leaks that maybe it's like the thrombus, that it's not so important, maybe, I don't know. But the leaks that it's like 3 mm or more, I think that with both techniques we will have the same measurements with MPR.
Okay.
With the patency or maybe this minimal less than 1 mm, maybe with TOE is not possible. But also the other thing is that we need to know where to measure, because we can measure with MPR, with CT or with echo, but it will depend on the device, and we also don't have an agreement with that. So.
Anyway, sorry.
So I think, first of all, we should stop to say it's 1 mm, 2 mm, because all the leaks are crescent shape. And maybe it's a good point from the Swiss Apero trial to measure the area of the leak, and then to define a cutoff or something like this, to say, okay, this is a dangerous area that is showing us where the LAA is not closed, and this is not dangerous. Maybe this is the best way, first of all, to define where is the cutoff. Because
yes, we are
1 mm can be everything.
We are moving from the diameter to the area. But coming back to your question, I think based on the data we have so far, it's very difficult to give strong recommendations about how to deal with the leak seen at the CT. With the TE is a bit easier based on the evidence we have. With the CT, we need to follow our patients in prospective studies and find still an association. And I completely agree with Kasper about I'm very skeptical about this study and the role of patency, because in our experience in Swiss Apero, and we will show the results at the ERA Congress at the end of March, we did not observe a similar association between patency and the clinical outcomes at 3 years.
And Roberto, isn't it even more complicated? I mean, you have shown that we have mixed device leaks in a certain amount of patients, and it's not neglectable. So shall we just sum up the area, or how do we cope with this?
Very good question. This is what we pre-specified at the beginning of our trial. We tried to give some definitions because based on those, there was a good inter-reader variability based on these definitions. But now we are moving slowly to a definition of side gap leak, including both mixed leak and peri-device leak, because are the leaks where we see a gap at the side of the device and where we see patency. So we are going to follow this side gap leak, including both entities. Yeah.
Yeah, I think even leak measurement on CT is sometimes even more complicated, because it's not just a crescent, it's sometimes a 3D thing. Like, where do you measure that crescent? It's the same like you have redo TAVI and you want to judge your coronary obstruction risk. It's a 3D dimension. You have your crescent gets bigger the further out you go, and it gets smaller the further in you go. And you measure the smallest then. I mean, I think it's very difficult to measure it also on CT sometimes.
But from a prognosis impact, that everything we say now will create a lot of confusion. You will detect more leaks, but the thing is what you do with the leak. What are you going to do with it? It's nice to when you have the CT, it's nice to see that you have done a good job. You have done you learn from your CT follow-up that you have to do in a better way and put it more proximal. Be careful with the proximal low and things like that. The thing is that if you start to, for example, on TE to measure the area, and so you end up with bigger leaks, so you will have to restart the process with thousands and thousands of patients to find a prognosis impact. Otherwise, it's just noise, and you don't know what to do with it. So you increase the anticoagulation, then you try to close it, and you don't know what you're doing. So for me, it's very disturbing.
Can I just go back to ELAACC patency again? We have devices that can create, in 70% of cases, complete closure. There's no contrast distal to the device, and we can all agree that this is a perfect result. Yeah. Okay, then we have 30% where there is contrast, and for me it indicates that there is an underlying problem. There's something going on. It can be a microleak, it can be maybe failed tissue overgrowth, but it indicates that there is an underlying problem. It can also be that the device is simply not good enough. The devices are not good enough to conform to the ELAACC anatomy, or the implanter is not good enough because we are using simple sheets that cannot be steered, so we are coaxial. Yeah. So I don't think that we can just in this club ignore ELAACC patency. No, sure. I think we should strive for a full closure also evaluated by CT, and I think that's also a message for the companies to look. I believe that there is an underlying, of course there is an underlying explanation for patency, and we need to have more data. Those Chinese data I agree that it can be a matter of who are the patients that have patency. Maybe it's the one that have very large atria, etc. But we need more data. We need to collect data and follow up. So I don't believe that we can just ignore it.
No, I didn't say that. I just the cutoff for severity. That's my main point. The prognosis impact.
I might just add this. This confusion I share. In the CONFORM trial, which is a very large 600-patient trial, we're allowing CT follow-up at a year and at 45 days. If there's a leak that is felt by the site to be at least 3 millimeters, we are asking, or the protocol has them also get a TEE, and that will trip the final endpoint. This has to do with conversations with FDA because they want consistency with previous studies, but this will provide a very good data set, be able to understand how to compare leaks, significant leaks, don't ask me to define that, seen on CT, and how they compare to TEE and having core lab reading of both.
Can I ask about treatment of leaks, because as you said, it's going on in the US that people are putting devices in. And how many here in this room is treating leaks with vascular plugs or coils or
that's the next
ablation
session,
energy, or is it the next?
Next session is exactly on that. But I was following up on your remark. Of course, it's interesting, this phenomenon of leakage by CT, but at the same time, we must be careful what people do with the information. So at our institution, we started at 5 years with routine follow-up, and the radiologist always wrote patency. And of course, this creates lots of confusion, not only for the referral doctor, who of course reads the CT report, and we had a meeting and we had to, we brought them to write clinically non-significant contrast patency. I think these are two important considerations. On the one hand, I agree, it's very important, it's potentially important, and we should opt for full closure. But on the other hand, you need to consider the current situation and what should we do with the information. No, the clinical situation. And currently, I think we agree there's nothing to do. But with patency, I'm not talking about PDL, but patency.
But with patency, we've also discussed earlier that might be incomplete endothelialization, and we've previously, as Sven said, in Protect AF and Prevail, the imaging finding was used to de-escalate anticoagulation therapy. So if you see patency, and if we believe that might be incomplete endothelialization, can we de-escalate? Yeah, but can we completely take them off antiplatelet therapy also? I would de-escalate, but we use aspirin monotherapy. But I think it's a question that we also need to investigate further, whether it's a risk factor. And clearly these patients in the Chinese study have a poor prognosis. But if they are sicker and have a higher CHA2DS2-VASc score, they might also heal poorly. So it might be delayed endothelialization. I don't know.
The thing is, just a question. So usually you put in the device, and if you say patency and it's explained by non-endothelialization, then basically a lot of people shouldn't have thrombus or connective tissue behind it. So in the animal model, after 12 weeks, there is no space. It's not perfused. And if you say, okay, you don't have a leak, but you have membrane patency because of non-endothelialization, there is a fibrin layer on top of it, so how should that function? And did you look at, flow velocities connected to leaks? Because actually you should have a lot of tissue in regardless of your leak, right? And if I see some picture, then there's just a cavity still there, which is surprising to me.
And I think all these discussions come back to we need to define the mechanism of the leak. We need to define the mechanism of the patency, and the current modalities we use can do that, but we're not good enough to do it. We need to define how we patency. Is it an uncovered lobe creating a PDL? That's one thing. Is it actually going through the device? Then I agree that on the backside, if you see some of the images, then the proximal part of the device will not be thrombosed, whereas perhaps the distal part will be. If you have a PDL, the distal part of the device will not be thrombosed, whereas the proximal part will be. So you can actually, looking at these images, discern the mechanism of the PDL or of contrast patency. That's my opinion, but we are not there yet to define how to do it.
And Kasper, for a clinical study endpoint, for a clinical standpoint, for a study, for an endpoint, you want to assess a device. For a company, which one they will choose? Actually, then it's unfair. I mean, you will do a device with a 3 months follow-up TE, very small leaks or almost no leaks or very few, and then you do the same device with a CT follow-up, and there is like a 30%, 40% patency. So my question is, when you use CT for surveillance of a particular device, I understand that you want to get a perfect closure, you want to understand the mechanism, but then you have not a fair comparison between the two modalities. Or you should have both, I think, like in the Swiss Apple, you should have both. I mean, for me, it's a gap that we need to address. I mean.
Yeah, and what if you come with a device like laminar on the market? I mean, then how are you going to discuss the discussion be then? I mean,
the CT of a laminar. I mean,
yeah, but they will almost never have leaks. They will probably never have DRT. Or is there going to be a clinical endpoint in that study that specifies leaks? I mean, this whole discussion we have because we have imperfect devices. Yes, that's the whole reason. But I think it's also really a difference between what is interesting and what should you do for research to really get the knowledge, or what should you do in the clinic. And I think in the clinic, let's be honest, we should keep it as simple as possible. Like, I'm even concerned hearing that, I mean, it's good if you do follow-up imaging a second time for research purposes, but for clinics, I mean, I think we also have to think of resource use and all that. I think it's definitely not what the patient also wants. What is the clinical significance of it in the pure clinic? Yes, and I think that you have to not lose out of sight too. And that's why also we do follow-up CT, and the protocol we write indeed is exactly the same. So we don't even want that word patency in it. We write, typically at 95% or 98% of patients, you write no DRT, no clinically significant peri-device leak. Boom. And that's the conclusion, yes? So even if there is patency, but then you scroll, you do a small, quick MPR, and you scroll through the device, you don't see any leak. And what is a clinically significant leak, by the way, for me? It's not even 1 or 3 or 5 millimeters. I don't care. I mean, I don't believe in all these cutoffs. It's more if I think, does it have a clinical consequence? Can I do something interventional here? Can I go in there with a plug, with a coil, whatever? And if not, then it's better not to do anything, and it's not a clinically significant. I don't have any proof to call it a clinically significant peri-device leak. You know, that's and I mean, it's a difference. For research, I would do something else. My rationale is different. I think differently. But for clinical practice, with the knowledge what we have now, we have to stay really practical and not worry patients or referrers unnecessarily, I think.
Can we agree that a 5 millimeter leak on TE cannot, the cutoff cannot be extrapolated to CT? Can we agree on that or not? Because, I mean, for me, it doesn't make sense to extrapolate, like the Chinese study has done, actually, to extrapolate the same cutoff from TE to CT. For me, it's a nonsense. Because probably when you have 5 millimeter on TE, probably it's even larger on CT.
Okay.
I mean, you don't have any study correlating the two measurements. I mean.
I'm thinking that it's not the leak, but it's what it causes. So should we do like head MRIs to the patient? So we see that if they get an emboli or minor changes, what doesn't cause any clinical significance, but those white spots, for example.
You mean for research?
Yeah, yes.
Not in clinical practice.
The association, but I mean, what is clear is that there is an association. It's not clear whether there is causality. That's not clear. That will only be clear if we do a randomized controlled trial, closure of leak versus no closure. And until that, there is an association. And there are many good reasons to think that there is no causality. Because as you said, Kasper, we'll show in the next session, there is really a gradient in atrial degree of atrial disease in those patients with PDL versus those without. These are different patients. They are much sicker. And that we also need to consider probably.
I think there's also one more thing that is clear, that talking about the which of a color jet, 3 or 5 millimeter, that is a simplification. And I agree, Ole, that we should keep clinical practice simple, but it's too simple. And I think there's a task for echocardiographers to describe that leaks should also be characterized by a 3D modality, because they are all crescent-shaped and not just a single diameter jet.
So I would like just to make a question to Jordi. I mean, for these cases, can like something like these softwares predict the performance of a leak in a certain situation? Would it be worth it just to, I would say, amplify the, for those cases? Because maybe we need more information, because maybe in one patient it's relevant, maybe in another it's not relevant. I don't know.
So it's true. I mean, the thing is that I've never have been lucky to run this kind of simulation. So first I have to see, but of course you can extract information from there. I don't know if it would be useful. I think that this is more wide opinion, but I mean, simulations, you can run it on it. What I think is that also would depend how contractile it would be, this left atrial appendage together with a leak. At least is what I've seen sometimes, that I play myself with the simulation, but it's...
Let's try to stay reasonable on time and close the session, because we can continue the discussion after a coffee break, because we have to talk about the consequences of diagnosing a DRT or a leak.